Good morning, ladies and gentlemen. Thank you for the possibility to present the results of our study. I have nothing to disclose. From the recently published study, we know that as pharmacological treatment is really not very effective, catheter ablation is, especially for the very selected patients with non-paroxysmal atrial fibrillation. Today I would like to present our results of total thoracoscopic ablation that is performed in our center. We perform during this surgery a bipolar radiofrequency line around the pulmonary vein and connecting lines on the left atrium. Also, we check acute bidirectional conduction block, and we do perform autonomic ganglia ablation and left atrium exclusion, left atrium appendage exclusion, of course. We use for this procedure Atrium system. On the right side, we also perform trigonal line, and on the left side, we dissect Marshall ligament and also stable the left atrium appendage with special precautions to avoid any stamp. We check this in a transesophageal echocardiography. To this study, we included patients with standalone non-paroxysmal atrial fibrillation without any structural heart disease and without thrombus in left atrium appendage confirmed in TE, preoperative TE examination. We already performed 34 ablations in a quite young patients population with typical comorbidities. 5 of them patients had a long-standing persistent atrial fibrillation. In this group, the left ventricle ejection fraction was slightly decreased, left atrium dimension was slightly increased. Also, there was increase in marker of left ventricle overload, and almost half of the patients were in symptomatic ERA class 4. In our follow-up, we observed no mortality, no stroke, and no postoperative bleedings. On admission to intensive care unit, 31 patients were in sinus rhythm. 13 patients required cardioversion during in-hospital stay. At the discharge, 97% of patients were in sinus rhythm. The one patient was actually already admitted to our hospital with complex rhythm disorders, and he was in atrial rhythm. In one patient, we were forced to perform a sternotomy because of a bleeding from left atrium which occurred during stapling. And in one patient, we were forced to abandon left pulmonary vein isolation due to very morbid obesity. During postoperative course, perioperative course, we noticed a slight increase in troponin and high sensitive troponin markers level. After 6 months, we observed 86% of patients in stable sinus rhythm. However, only 13% were off anti-arrhythmic drugs. After 12 months, we observed 84% of patients in stable sinus rhythm, and here was almost 1/4 patients off anti-arrhythmic drugs. After 2 years, we observed that 6 out of 6 patients were still in sinus rhythm. However, only 1/3 was off anti-arrhythmic drugs. But still, this group of patients is very, very small. We also observed a decrease in NT-proBNP level and slightly increase of left ventricle ejection fraction. However, there were no statistical significance. Left atrium dimension was quite stable during the follow-up, but we observed good atrial function defined as a return of E-wave in patients with preoperative arrhythmia and good E to A ratio. In conclusion, in our experience, total thoracoscopic ablation is feasible and gives quite promising and good results in maintenance of stable sinus rhythm. But still, this should be more. Further studies are quite needed. However, the main limitations of our study is that very many patients are still on anti-arrhythmic drugs. It's mainly due to referring physicians, and we were able to obtain only 48-hour ECG Holter monitoring. However, for all of our patients, And we are still waiting for the electrophysiological evaluation of whole group, which is planned to be on the end of June. Thank you very much for your attention.
Thank you very much. Any question? I actually, maybe in the meanwhile, I have a question for you. I've seen that in your results that about 38–40% of patients are receiving electrical cardioversion while in hospital, so still pretty early. I was just wondering, is your protocol pretty aggressive in early cardioversion?
Yes. We believe that early cardioversion, early electric cardioversion is the best for those patients in order to keep up with sinus rhythm as fast as it's possible.
Do you also have a protocol for trying to reduce, because I'm sure you guys know as well very well that there is a very kind of inflammatory substrate early after surgery. So, for example, we give steroids. Do you, for example,
no steroids
early after to prevent,
Rather not. No. We just do anti-arrhythmic drugs, statins, and anticoagulation, but we do not use in period steroids.
Thank you. Excellent results. Wolf?
Well, thank you. That was a very nice paper.
Thank you much.
It may be that all patients that have long-standing persistent atrial fibrillation are not alike. For example, if a patient has been in continuous atrial fibrillation for more than 12 months and also failed cardioversion, that's long-standing persistent AFib. Yes. But also there's a patient that may be in continuous AFib for 20 years. They both are in the same category, long-standing persistent AFib. But in fact, they're probably not the same patient. And I think that's why we keep falling back on the size of the left atrium. That still seems to be the best. Maybe that's a way to look at how long the heart's really been out of rhythm and what the structural changes are in the fibrosis. So maybe I missed it, but did you correlate your success to the size of the left atrium?
We tried, but we obtained no significance. The probe is still very small, and there was no statistical significance between those parameters. Also, we correlate other parameters like time of duration, ejection fraction, NT-proBNP, as I said, but as for now, we didn't obtain any significance. Maybe because the probe is, the count of patients is very small and they are quite selected.
So maybe you didn't have any patients with very large left atrium.
Yes, I didn't say that, but it was on this on presentation that we rather exclude patients with atria over 7 centimeters. They were proposed for a minimally invasive but still a MACE procedure with in cardiopulmonary bypass.
Left atrium larger than 7 centimeters?
Oh, yes. It also depends on the whole patient. It's not only the diameter of atrium that shows us that we should perform thoracoscopic or minimally invasive, but because it's the whole disease is an indication for the special treatment.
There's one other possibility. If you're on the left side and you're having difficulty accessing the pulmonary veins on the left, one thing that you can do is make a non-rib spreading incision in the fourth intercostal space, use a sponge stick and retract all that fat anteriorly, and then you'll usually see a clear space behind the phrenic nerve to open. So maybe something you can consider. Sometimes you can't do the case totally endoscopic, but you can make a small incision and still complete the case.
We try to do this also. We try to complete those procedures totally thoracoscopics, but sometimes it's happened that we have to perform small incision. It was this one patient that was abandoned from the left pulmonary vein insulation. We started with thoracoscopy, then we were unable to even put all those devices into her chest, so we performed mini thoracotomy, but it was still
Okay.
impossible to do this safely. At the end, we tried to at least excise the left atrium appendage, but it was also too dangerous for us, that we decided to just refer her to
Sure.
EP.
Sure.
Okay, thank you very much.